Hello, welcome to Case Study 4. I'm Professor Donna Brunson. I'm a psychiatric nurse practitioner, board certified. This case study is thus. You're called to consult on a 26-year-old male who presented to the emergency department in handcuffs. He's escorted by two policemen. He was found at Walmart in the electronics department yelling at the televisions. When store personnel requested that he leave the store, he became very belligerent and threatening. He refuses to engage in much of the interview except to say, "Let me go or they are going to get me. They are trying to kill me." They are all in it together. Upon review of previous medical records, you note that the patient has had several similar encounters over a 5-year period with inpatient admissions for psychiatric care. The patient's urine drug screen is negative for any substances. Previous reports note that he is estranged from his family. He has no known address. He denies being depressed, suicidal, or homicidal. He does admit that he can hear the people on the TV threatening him. The patient refuses to provide any contact from which to gather collateral information. In this case, we're also going to talk about subjective information, the importance of subjective and objective information. Subjective, as the word suggests, this type of data refers to information that's spontaneously shared with you by the patient or in response to questions that you ask the patient. Thus, when we do our psychiatric assessment. Subjective data can include information about both the symptoms and the signs. Example, we're going to assess what is the chief complaint, what is the time frame, triggers, recent changes, any modifying factors, what's made things worse, what's made things better, functional ability, interpersonal relationships. We also are looking at the psychiatric review of symptoms. Safety. Does the patient have any current or past suicidal thoughts? Current or past homicidal thoughts? Is the patient medication compliant? If not, why did the patient stop taking the medication? This can often overlap with objective data. We also want to look at substance use, any trauma history, social developmental delays, and history of families. Example, is there a family history of bipolar disorder, schizophrenia, depression, or suicide attempts? All this is needed information to gather a picture of what's happening with this patient. Objective information. Objective data refers to information that we can measure. This is done through a physical exam or observing the patient, diagnostic testing. Examples of objective data include, but aren't limited to, physical findings, the patient's behaviors that we're observing, lab results, and the patient's vital signs. Objective behavior can be the mental status exam, appearance, behavior, attitude, speech, affect, mood, thought process, thought content. A physical exam, we want to get the height, weight, BMI, vital signs. Labs, we certainly want to get a CBC, a CMP, a TSH, thyroid stimulating, RPR for syphilis, urinalysis, and a CK level. Screening tools, there are many. There are many screening tools, including the PHQ-9, PA-NIS. There's just very many of them. As far as imaging goes, oftentimes if there is to check for a change of mental status, a CT of the head may be ordered. I have done this quite often as I've worked completely in the emergency room for psychiatry for the last 15 years. So I have ordered many of all of these labs. I'm trying to rule out what it is not. And what it is not, we're left with what it is. So the differential diagnosis for this patient could be substance-induced psychotic disorder. To be considered for substance-induced psychosis, the hallucinations and delusions should be in excess of those that typically accompany simple substance intoxication or possibly withdrawal. In this case, we already know that the UDS is negative for any drugs on board. So we can toss out this differential. The second diagnosis, possibly differential, schizoaffective disorder. How is schizoaffective disorder different from schizophrenia and the DSM-5? That's a good question. There's a key difference between schizoaffective disorder and schizophrenia is the prominence of a mood disorder. With schizoaffective disorder, that mood disorder is front and center. With schizophrenia, it's not. In this patient's case, there's no known mood disorder. A third differential, possibly, major depressive disorder with psychotic features. Were the diagnostic criteria for depression with psychotic features? Persistent feelings of sadness, anger, irritability. Well, let's think back. Did we see this in the patient that we interviewed? Did our assessment find this? Feelings of worthlessness. The patient didn't say that. There was no mention of change in appetite, nothing about sleep, nothing about being depressed. So we can say it is not this diagnosis as well. So what is the diagnosis and what's the treatment plan? I have worked in the psychiatric emergency room for many years. I've worked in countless emergency rooms. I see this patient quite often, unfortunately. So for this patient, my diagnosis is schizophrenia paranoid type. He's very paranoid. He believes that people are out to get him and out to harm him, the threatening voices. So, diagnosis schizophrenia paranoid type, a type of schizophrenia in which these following criteria are met: a preoccupation with one or more delusions or frequent auditory hallucinations. We already know he's having frequent auditory hallucinations, and he believes the televisions are talking to him. And you will see none of the following is prominent. He had no disorganized speech. He wasn't catatonic. His affect was not flat or inappropriate. So what are we going to do for this patient? Our treatment plan will consist of he's going to need to be involuntarily admitted to psychiatric unit. And for treatment, the police brought him in handcuffs, means he did not come willingly. I typically will have a CBC, a CMP, a CK level, and EKG. I often check the CK level to look for any kind of rhabdomyosis that might be happening. I see this often in patients, sometimes as a result of drug use, sometimes the result of the use of antipsychotics. But in this case, the patient is definitely not taking medications. I will attempt to contact the family for collateral. Most assuredly, this patient's homeless, so it's doubtful we'll be able to get any information. I will educate the patient on recommended medication. While this will be difficult, it is important that I want the patient as much as possible to understand why we recommend this treatment. I often will start palperidone, usually 3 milligrams at bedtime, to determine tolerability to this medication, as I quite often recommend for schizophrenia, non-compliant with medications, long-term injectables such as Invega Sustenna. You're going to start the 3 milligrams at bedtime because we're going to make sure the patient's tolerant of it and monitor for any side effects. So very often, again, I see this patient very similarly afflicted in the emergency room. I have found that long-term injectables are very, very helpful in this case. Thank you very much.